Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome back to the second day of the NIN Jakarta International Chest and Critical Care Internal Medicine or GIC-CIM 2021 live webinar. My name is Trian Satrio and I will be your host for today's event. Today we'll be having two keynote lecture and two lecture sessions. We are sure that today's session will enrich our knowledge and understanding even more. Before getting into the keynote lecture, we would like to remind you that first, all participants of GIC-CIM 2021 are expected to attend the webinar attentively. Certificate will only be given to participants who attend at least 70% of the whole webinar. Second, participants may use Q&A feature in Zoom webinar if they have any question for the speakers. You can ask the question in the middle of the lecture. There is no need to wait until the speaker is done speaking. The third, every week on Sundays, after the e-poster session, there will be door prize announcement. There will be 3 prizes every week, given to the most active and attentive participant. For the first 2 weeks, prize will be Bluetooth speakers, smartwatch, and Bluetooth earphones. There will also be an added bicycle as the grand prize of the final week. Ladies and gentlemen, we'll now hear the second keynote lecture about aerosol therapy for pulmonary disease in pandemic era, which will be delivered by Professor Jayes Dandani, MD, MBBS, PhD, PG Diploma, FCICM. Professor Dandani is an associate professor in the University of Queensland, Australia, and an intensive care specialist at the Royal Brisbane and Women's Hospital and the Prince Charles Hospital. Currently, he is involved in a path-breaking research in the field of pulmonary drugs delivery for local and systemic effect that has wide application across diverse patient groups. Without further ado, Professor Jayes Dandani, the floor is yours.
Thank you very much for the kind introduction, and thank you very much for inviting me to speak at this grand occasion, actually. I'll try and share my screen now for the presentation without wasting much of your time. Okay, let's see. Okay, just want to confirm, can you see my screen all right? Are you able to see my screen?
Yes, Professor, I can see your screen clearly.
Oh, fabulous. Is this the screen that you're seeing? Which of the screens are you actually seeing? The slide screen that you're seeing?
Okay, Professor, it's already better.
Sorry for magical glitch, actually. Without wasting much of your time, actually, we'll start with this presentation, an important topic, actually, especially in the context of this pandemic. I would like to share with you an interesting case that we looked after a little while back, actually. It's a case that actually is very close to my heart and has actually changed the way I looked at aerosol therapy. So we've got a 65-year-old male that presented with chest pain and hemoptysis, had a very short history of some very simple conditions like asthma, obesity, and hypertension. Had a clinical feature which suggested that a patient needed higher amount of oxygen on high flow at 60 to 70% oxygen. Chest X-ray showed a mild opacity in the left mid zone, but because it was unclear at the time whether it was infection or a non-infective condition, we performed a CTPA, and that showed that the patient had pulmonary embolism. Here, the CT shows the extent of the pulmonary embolism, and it also has this wedge-shaped infarct, which confirmed the evidence of pulmonary infarct as a result of pulmonary embolism. This lesion eventually cavitated, and that was the reason the patient had continued hemoptysis. The treatment strategy in these conditions usually consists of a number of interventions that you could actually embark on, such as endobronchial therapies in the form of hemoptysis controlling therapies, interventional radiological therapies with bronchial artery embolization and some vascular embolization procedures that you could perform. But what we did was nebulized 500 milligrams 6-hourly of tranexamic acid. After 4 doses, the patient stopped having any form of hemoptysis, and we could then commence on the definitive treatment for pulmonary embolism, as you know, with systemic heparinization. That was commenced about 12 hours later. The patient was subsequently able to be weaned off all form of oxygen support over a 8-day period and was discharged home after 15 days on warfarin, which was meant to be continued for about 6 months. And this is what we saw on the X-ray. So here is the initial X-ray, then the cavitation, and this is the latest X-ray, which suggested that there was a good resolution of the area of lung infarct and the lung cavitation, which was responsible for the hemoptysis. But this condition or this case actually reinforced my view of a local treatment for a local problem. And here's the philosophy that we follow, which is basically a case of aerosol therapy, which has an early onset of action, achieves higher local concentration with reduced systemic side effects. And in fact, in local conditions such as, say, asthma, in lung infections, as well as in this condition with tranexamic acid, you could actually get away with really small doses of drugs for a very locally effective therapy. So today we'll discuss aerosol therapy, and we'll discuss on the principles of understanding some background to the aerosol therapy, and then look at what are the current problems that we are dealing with, especially in the context of pandemic, what are the possible solutions, and what should we look at with future directions. So commonest indicators of using aerosol therapy in medicine in general is basically for local effects, using bronchodilators, steroids, recently increasing evidence to support use of antibiotics for lung infection, both for airway in the form of ventilator-associated tracheobronchitis, bronchiectasis. Surfactant has been around for aerosol therapy for a little while. The evidence in adult medicine is a little bit scarce. There's a little bit of evidence in pediatric population. There's more and more evidence of using pulmonary vasodilators to improve ventilator perfusion mismatch in patients who are hypoxic and in pulmonary hypertension, obviously. When you actually want systemic effects, we could deliver insulin, and currently sedative analgesics are being increasingly being seen to be one of the other agents that could be used via inhalation therapy for systemic effects. In general, factors that affect drug efficacy, especially for aerosol drug efficacy, can be considered as drug, mug, and bug. Now, the drug is obvious, mug is the patient, bug is the disease, and the disease could be infection or non-infective condition. In the context of aerosol drug therapy, the drug delivery is the rate limiting step, and it's actually being seen increasingly in evidence that we'll continue seeing through this presentation. So let's consider some of the factors that affect in aerosol drug delivery or inhaled drug delivery and deposition. And here it is. So drug effects, drug formulation related issues such as the particle size, the volume of the nebulizer, for example, device related factors such as the type of the nebulizer, the position of the nebulizer, especially in the context of using with high flow nasal prongs and ventilator circuits. Nebulization time is also another factor. When you use with ventilators and non-invasive ventilators, then there are some ventilator-specific parameters, circuit-specific parameters, and finally, patient-specific parameters, which affect drug delivery and therefore drug effect. And we'll consider that in a little bit of detail going forward. Some formulation related factors that are important is to consider the fact that safety comes first, and patients who actually get delivered non-physiological pH or hyperosmotic formulation for aerosol therapy seem to have significant amount of bronchospasm and intolerance of therapy, which then affects obviously the drug efficacy and the ability to deliver a good amount of aerosol drugs. When it comes to other formulation related component, now this is seen to be increasingly as a common factor, which is called as particle size. What is particle size? The particle size is the size of the aerosol that gets emitted from the delivery device. Now, why is it important? It's because, as you see in this diagram here, the 1 to 5 micron particle size range is the one that actually gives you maximum deposition in the distal part of the lung. Now, for drug deposition, drug effect, you need the drug concentrations to be highest at the site of action. And for all the drugs that we mentioned previously, including bronchodilators, you want as much distal lung delivery as possible for its clinical effect. And therefore, the 1 to 5 micron particle size range is desirable for maximal drug effect. Moving on to drug delivery devices. Now, currently we are in the third generation of drug delivery devices or aerosol drug delivery devices. We know we are very familiar with this device called as the jet nebulizer, which behaves or is as effective with gas flow and works on the principles of Bernoulli phenomenon. The second generation nebulizer is the ultrasonic nebulizer. And the issue with the ultrasonic nebulizer was the fact that there was quite a lot of heat generation, which causes drug denaturation and drug degradation, reducing the amount of effective drug that you could deliver. And the current nebulizer that we see is the third generation nebulizer here. And that's actually, this is a prototype. It's a vibrating mesh nebulizer. That's the one that is being commonly used in most of the tertiary hospitals. The principle behind the vibrating mesh nebulizer is that you have a plate up here, which is a plate which has got about 1,000 holes, which are precision holes meant to generate particles of 1 to 5 micron size range when an electric current is actually passed through a piezoelectric crystal, which makes the plate vibrate at a higher frequency. Then the solution which sits on the plate is broken down into aerosols of 1 to 5 microns for effective distal lung delivery for clinical effect. Now let's see what the evidence suggests. Here is the evidence with jet nebulizer, and this is in context with mechanical ventilation, and you see the combination of non-intubated patients and intubated patients. The difference is quite significant. You see that only in 3% of the intubated patients we get the deposition in the distal lungs, and in non-intubated patient, it's still 12%, which is higher than 3%, but it's quite low as compared to what you actually need for clinical effect. Mesh nebulizer has got other advantages as well. There is minimal rain out. There is optimal particle size. It maintains drug integrity in the sense that there is no drug degradation, which is what we saw in patients who got ultrasonic nebulization, and because that there is no heat generated. This diagram also shows you what actually happens with the different sizes of the particles, where the larger particles are predominantly deposited in the proximal airway, whereas the particle size of 1 to 5 micron is what gets deposited distally. And that's the area of interest. That's the particle size that we want to achieve. And so you'll realize increasingly how important it is that the delivery device and the formulation combination is good enough to achieve those particle size for effective lung deposition and therefore drug effect. Here is another example. We see even at different positions in the circuit, in the ventilator circuit, for example, you see the difference between the mesh nebulizer and the jet nebulizer. The mesh nebulizer effect is in the blue, and the gray is the jet nebulizer, and we see the difference in the amount of drug that gets deposited. So here is the nominal dose, and here is the different position. And so even with different positions, it makes no difference that the fact that the mesh nebulizer is quite superior to the jet nebulizer when it comes to drug delivery. The position of the nebulizer is quite important to consider when we actually decide to nebulize any drugs. In mechanically ventilated patients, for example, the best position found is in the inspiratory limb, 15 centimeter from the Y-piece. When using with a non-invasive ventilator, it's after the exhalation port. When using with the high flow nasal bronch, it is with the dry side of the humidifier. So these positions are quite important to reduce drug wastage so that there is maximum amount of drug available for clinical effect. Now let's look at some specific considerations, especially with mechanical ventilation. We've spoken about some principles that we looked at generally for all nebulization, but when it comes to mechanical ventilation, there are some special considerations. So re-looking at the factors that we saw earlier, it's the ventilator factor and the circuit factor that are quite important actually, apart from the formulation and the device factor that we saw. What are the ventilator related factors? Ventilator related factors that we could see clearly are respiratory rate, waveform, tidal volume, and the mode of ventilation. What is the circuit related factors? So tube size, humidification, and gas density. Let's consider them. So here is humidification. Now, humidification is commonly utilized in mechanically ventilated patients, and that's to prevent atelectasis. And the reason for atelectasis that happens in non-humidified circuit is by having very thick sputum, which is dry and forms sputum plugs. Different ways of delivering humidification in mechanically ventilated patients is through HME and heated humidifier. In the context of heated humidifiers, for example, we see how the difference is actually even with two different nebulizers. You see the significant difference with humidification. So here you could see that the humidification reduces the amount of inhaled drug mass, whereas with a dry circuit, the inhaled drug mass is higher. Why is that? It's because the humidification adds water particles to the aerosols and increases the size of the aerosols. And as we saw earlier in the previous diagram, where the large size particles get deposited in the proximal airway, which is not what we want. So humidification and turning off humidification is one of the key points we would normally recommend during aerosol therapy. Using HME, if you were to use HME, it is ideal to remove HME during the process of aerosol and then replace it once the aerosol therapy is finished. Other factors that affect aerosol delivery is viscosity. Now, how does viscosity change aerosol delivery? Now, you could see that here again. Here's the effect of viscosity as you actually have increasing viscosity, the fine particle fraction. Now, this fine particle fraction is nothing but the 1 to 5 micron particle size range. And the percentage of that particle size range in the aerosol is called as a fine particle fraction. Now, why does this happen? Again, with less viscosity, it means that there is more water content in the solution, and therefore the fine particle size fraction is lesser. As the viscosity increases, the fine particle size actually increases. Over time, though, does this actually continue? The answer is no. What happens is, as the viscosity increases, yes, the fine particle fraction improves, but after a certain amount of viscosity, the solution gets so thick that it actually clogs that mesh hole, and therefore the emission of the aerosol becomes lesser. And so the actual fine particle fraction reduces rather than increases as the viscosity increases above a certain value. Ventilator parameters of note are the airflow rate and pattern, tidal volume, respiratory rate, and mode of ventilation. Now, the principle behind this is to enable laminar airflow, so smooth laminar airflow rather than turbulent airflow, and higher inspiratory rate or a higher inspiratory time will obviously facilitate more time available for the air to take the aerosol into the distal lung for clinical effect. Here's the example of what happens with different modes of ventilation. So you see the pressure control, pressure support mode ventilation and the volume controlled ventilation. With difference in the different modes, you see that amount of deposition changes from 10% in pressure support to 15% in volume controlled ventilation. So that's the significance of using a controlled ventilation mode during aerosol therapy. Again, it says quite clearly that we do have a higher amount of deposition using a mesh nebulizer as compared to a jet nebulizer, even in different positions along the ventilator circuit. And so therefore, again, reinforcing the point that I made earlier, that the delivery is the key to drug effect when it comes to aerosol delivery and aerosol therapy. And therefore, a combination of the right type of drug delivery device is so important, including obviously the formulation related factors that we just discussed as well. But it's interesting, despite all that, so this is one of my previous studies that we did comparing nebulized versus IV nuclear radio-labeled tobramycin in a controlled large animal model. And despite optimizing all the factors that we discussed earlier, we could still see that the deposition remained low. Now, that deposition, remember, in the lung is quite tricky to evaluate exactly where that deposition is. So yes, IV is about 57%, but is that in the vascular territory? Is that in the interstitium, or is that in the alveoli? Now, what we did in this case is follow this up with a microdialysis type of study with positioning small catheters in the lung and measuring the drug concentrations in the lung. And not surprisingly, what we found is the concentration in the site of effect, which is the interstitium, was higher, about 10 times higher when you deliver the drug via the aerosol therapy as compared to intravenous therapy. Why? Because the lung is a composite. The lung is not a homogeneous organ. You have the alveoli, you have the interstitium, and you have the vascular territory. Most of this 57% that we see here was not in the interstitium, which is the site of action. It was entirely or predominantly in the vascular territory rather than in the interstitium. And so it gives you a false sense of assumption that surely the IV therapy is better. But even that 8% achieved a much higher interstitial drug concentration as compared to intravenous therapy. So we'll be dealing with a very bad pandemic currently. It's a once in a lifetime, once in a 100-year pandemic, which has led to a significant amount of mortality and morbidity, and continues to be a cause of concern universally. And as we know, a number of countries are going through a number of peaks currently. Some countries are going through the second spike, some countries are going through the third spike, and it is likely that this is going to be an ongoing problem. Aerosol therapy and COVID is like a problem with each other. Aerosol therapy is considered to be a problem in COVID, especially because aerosol is one of the modality of transmission in COVID. Having said that, the risk is quite minuscule. Why? Because the therapeutic aerosols themselves do not add to the risk of the disease transmission unless the aerosols are contaminated by the patients or the healthcare workers. So the difficulty is to separate out between aerosol-related transmission, but aerosol that is required for pharmacotherapy. And therefore, I think we need to understand that very carefully before you before we subject patients and caregivers to any form of harm. There are some things we could still do and effectively implement in patient care and still be able to provide effective pharmacotherapy in these patients. So some of the principles that are worth considering to safely deliver these drugs is that PMDI, which is the metered dose inhaler, pressurized metered dose inhaler, are no better than nebulizers, especially when it comes to preventing fugitive emissions causing transmission of infections. It's better to preferably use disposable mesh nebulizers. So use it for a particular patient, and once that is finished, obviously do not reuse them. Disposing is the best strategy. Reusable nebulizers in the same patient could be sterilized. Using PPE and social distancing is important during therapy. So for the caregivers, it is important that we follow those principles. And reducing the formulations that induce coughing, such as distilled water and hypotonic saline, is an ideal strategy. Why? Because interestingly, of all the aerosol generating procedures, the coughing seems to be the one thing that does actually cause further transmission of infection, because that has got a highest amount of viral burden to cause aerosol related transmission of infections. Some practical strategies that we could use for looking after patients in COVID-19, especially in the context of aerosol therapy. If it is a mild condition, we could potentially avoid it, but if you do have to use it, use the nebulizers with mouthpiece or with high flow nasal cannula. Not to use the face mask with nebulizers is ideal, again, to prevent the spread of the fugitive emissions, which could spread infections. Adding filter to the other end of the mouthpiece, especially if you're using oral aerosols, is ideal to prevent contamination of the environment and infection transmission. Prefer to nebulize in negative pressure rooms, and obviously the caregivers are better off wearing a PPE. When it comes to looking after patients with moderate conditions, surgical mask on top of the high flow nasal cannula, this is quite interesting, I found, and quite effective. Over here in Australia, although we've seen less burden of disease, when we've looked after patients with COVID-19 on high flow nasal therapy, especially when providing aerosol therapy with high flow nasal cannula, putting the surgical mask on top of the high flow nasal cannula seemed to reduce the fugitive emissions and aerosol transmission. Performing nebulization in negative pressure rooms and wearing full PPE for the caregivers is also important. In intensive care, it's best to use an inline nebulizer, closed circuit inline nebulizer, preferably mesh nebulizer, as we discussed earlier. And the advantage of that is you can add the medications to the nebulizer without breaking the circuit, and therefore reducing the amount of aerosol transmission that can occur during therapy. Placing the nebulizer before the humidifier could be done to improve the drug efficiency. Adding a filter to the expiratory limb again will reduce the amount of transmission, and therefore changing the filter after a therapy is also recommended. Again, inline or closed system suctioning and wearing PPE in a negative pressure room is all ideal, if possible, actually, during aerosol therapy. Now, this is one setup with patients who are with tracheostomy. We could see that. So here is the tracheostomy tube. You then have the circuit which provides oxygen. The nebulizer sits in the circuit at that position. And the reason for that, as compared to directly putting on the tracheostomy, is interesting. So the nebulization is a continuous process, whereas the ventilation is an intermittent process. What would happen is, during exhalation, if you put the nebulizer directly here, then half the drug is lost. What this actually provides is a reservoir. So during exhalation, while the patient is breathing out, the nebulized drug will sit in this reservoir, and with the next breath, the patient will breathe in that aerosolized drug, and the patient's drug loss will be lesser. During exhalation, the exhaled breath is captured in this filter, and thus preventing a fugitive emissions in the form of aerosol transmission of COVID conditions. It's important to remember to change this filter though, because this filter over time will get soggy and will provide an expiratory obstruction. So it's important to prevent that, otherwise patient harm in the form of barotrauma could occur as well. This is the picture that demonstrates what you can do with high flow nasal cannula. So this is the high flow nasal cannula setup. And over that, one can put in a mask which prevents aerosol transmission. So you could have the aerosol provided in the circuit itself on the dry side of the humidifier, and then provide this surgical mask to cover the face, preventing the fugitive emissions, which can cause infection transmission. So, in conclusion, we need to understand the basics of aerosol therapy to effectively deliver treatment in the first instance. So drug delivery is the rate limiting step, and one must optimize that by all the factors as much as possible. Mesh nebulizer is the preferred delivery device. We should consider factors to optimize drug delivery. And one must understand, yes, the mesh nebulizer is moderately expensive as compared to the jet nebulizer. But at the end of the day, if we want maximal clinical effect, then one must actually look at optimizing delivery by using the best delivery device. In the context of COVID-19, it is important to use the nebulizer with mouthpiece and a high flow nasal cannula. Surgical mask could be used on top of the high flow nasal cannula to reduce fugitive emissions. Performing aerosol therapy using PPE and negative pressure rooms is ideal, and mesh nebulizer use with filters is preferable to reduce aerosol transmission. I could see the future in this area of medicine going quite dramatically, where newer formulations will come into picture. Already there are about 120 articles, studies being registered on the clinicaltrials.gov website looking at aerosol therapy for COVID, which is interesting actually. 120 studies being registered just looking at aerosol therapy for COVID. And this is for effective therapy for COVID, that is with remdesivir and GM-CSF, as well as interferon therapy. So watch this space. I think by the time the pandemic finishes, we'll see a lot of treatment with aerosol therapy in COVID conditions. PK/PD studies are important to